Thanks, and this is the final session for this bit of a marathon that we've had the last 2 days. We are now going to go back to thinking about care homes, and we're going to be in this session looking at the experiences and impacts of implementing COVID-19 related measures in care homes. We're actually I'm using the word care home, but we're actually going to start by looking at continuing care retirement communities in Israel with Liat Ayalon. The second paper is going to be from a very new study in Catalonia, Spain, presented by Pau Moreno. It's called COVID, and this is just a starting study. And then we will finish with, back in the Netherlands, actually, with the presentation from Lisa Van Tol on isolation and distancing measures in Dutch nursing homes. So I'm going to start with Liat. The floor is yours. If you want to see if you can share your slides, and we can jump in if you need any help with that. We don't hear you yet, Liat. Sorry.
Hi again.
Hi.
That's the beauty of Zoom, right? So hi, everyone. Thanks for the invitation to present here today. I will be briefly presenting 2 studies that I conducted with my colleague, Dr. Sharon Avidor. And these papers were conducted in Israel during the first wave of the pandemic, when restrictions were actually quite intense. The framework actually that we adapted in conducting both studies was that of ageism. And basically we have seen many instances of ageism, both in terms of stereotypes, putting older people or portraying older people as highly vulnerable, but also a burden to society, in terms of prejudice, the way we feel towards older people, and also in terms of discrimination. And we have seen these instances of ageism during the pandemic, especially the first wave of the pandemic. I think throughout the world, we were quite shocked by that. And thinking about it, it's clear that at least during the first wave, COVID-19 was portrayed as an illness of older people. And that's the message that everyone received. And it really resulted, I think, in generations pitting against each other, and in younger people thinking that's not their disease. Nonetheless, these messages have somewhat changed over time. Our thinking about the pandemic that was accompanied the pandemic of Corona, and this is the pandemic of ageism, and 2 main theories can possibly explain why it has increased so dramatically during the Corona time. First theory is the terror management theory that talks about our own anxiety and fear of seeing older people, seeing vulnerable people, because it really brings us closer to the understanding that we are not immortal, that we also are not going to live in this world forever. And we're trying to shy away from that because it really creates a lot of anxiety in us. During the pandemic, death was pretty much all the time associated with older age. And this really has increased our anxiety, I think, and our reaction towards older people. A second theory concerns competition over scarce resources. And basically, there is this idea that I think is quite ingrained in all of us, or in many of us, which says that older people should not consume too much and should move away and give the right of the way to younger people. I think in the workforce, we see it very clearly in mandatory retirement age, but we have seen that also with regard to the pandemic and the management of the pandemic in a variety of incidents, including lockdown, exit, and triage strategies, as well as vaccines. And all these instances really have used chronological age as a criterion, as an arbitrary criterion, either for lockdown, exit, triage, long-term care, and I will be talking about that much more substantially, and the vaccines. In terms of long-term care, I'm sure that after a day and a half listening to research conducted in long-term care around the world, I should not be reiterating these various horrific news that we have heard from all over the world about residents being abandoned, bodies being hidden for days, and so forth. I do want to say, and maybe just repeat the fact that long-term care settings have been deprived of resources even before the pandemic. So it's not news. The problem is that during the pandemic, these settings really required permanent staff and available PPE, personal protective equipment, which was not available because of this very long-term deprivation of long-term care settings all over the world. The study that I will be describing actually was conducted in CCRCs, in continuing care retirement communities in Israel. These settings, at least in Israel, are privately owned. They are available to more affluent older people who, at least upon entering these settings, are independent in their activities of daily living. And in fact, if you ask these people for the reasons of entering these settings, a major reason is to keep their autonomy and to be able to continue caring for themselves as long as they can. And then they can opt for a sliding or a varied type of social services as they need. Nonetheless, during the pandemic, during the first wave of the pandemic, these people were confined to their units for months, even longer than the rest of the population. We conducted interviews with older people who have been living in these continuing care retirement settings. And what we found was that these people reported a rupture between their life before, that was described pretty much as ideal, versus life after COVID, where their autonomy was taken away from them. And they have noticed major power imbalance between themselves and staff. Many of these residents have used downward comparisons to portray to us the fact that maybe their situation actually is not that bad, and that the situation of other older people in the community is worse than theirs. So here is one quote. Those who are alone in the community, my friends who are alone, they're simply jealous of us because they're saying, you're in a cage, but a cage of gold, because you're being spoiled. Nonetheless, despite this use of downward comparison, all the residents that we interviewed have noticed a power imbalance that became much bigger during the first wave of the pandemic, when they were actually restricted to their units, to their living units for a couple of months, when the rest of society actually ended up going back to the community and started to adjust it to a new routine. So here is one quote that describes this power imbalance that the residents have noticed. Initially, no one spoke about the effects of the pandemic. They, staff, knew that one died, but no information in order not to burden the residents. No information on the notification system, nothing. But by a coincidence, my room is here, right above the balcony, and all staff meetings were underneath. So this resident is really discussing the fact that she was not well informed about all the events that were taking place during the pandemic, major events. People were infected, people died, and nothing was discussed. So she really had noticed the power imbalance, where staff had all the knowledge. Staff also was able to go back to their home. Staff was able to tell people to go or not to go to medical care. So basically, this is when the residents have really noticed change in their relationship with residents. Another major theme that we identified in these qualitative interviews was that of traumas. And many of the residents that we interviewed were actually Holocaust survivors. And the pandemic has brought them back 60, 70 years ago to the time of the Holocaust. And this is one quote. From that period, when I was 7, 8 years old, all alone among strangers in a threatening world, I have learned how to block my feelings when I needed to. So that girl has become my counselor during lockdown. Even now, the girl is saying, I'm getting over this. I am not thinking about this. I am shutting this out. I reorganize things. And another resident put it this way: we have become prisoners of our own age during the pandemic. To conclude, based on these interviews with CCRC residents, it is clear that residents' defense mechanisms were successful to some extent, but as time went by and the rest of the country actually returned to a new routine, these mechanisms had collapsed, and all the residents experienced high levels of stress, anxiety, depression, despair, and trauma. And if I describe the CCRCs, I would say that at least in Israel, they were quite successful in physically protecting older people, but it came at the price of compromising older people's well-being. I am now just briefly discussing another study that was conducted actually with family members of residents, both in continuing care retirement communities, but also in nursing homes. And what these family members reported, and again, these are qualitative interviews, they reported that older people in long-term care settings, especially those who had more complex medical needs, have experienced substantial functional decline as a result of the unavailability of medical care, as well as symptoms of depression and anxiety. Family caregivers also reported about themselves increased worries, guilt, but also some reported a sense of relief because really they felt as if it was difficult or impossible for them to keep their loved ones at home. So at least these people were protected in the long-term care setting. And these are two cohorts from two family members. It was very difficult for my mother, very difficult. This isolation, without being able to visit her and not letting her out, she couldn't quite understand. She started saying it was Hitler who sent this virus. She started hallucinating and seeing things. So this person is really reporting a cognitive deterioration as a result of isolation. Here's another member saying, this time about herself, there's no end in sight. Do I know if she will live another year? I think the place is dealing with it just fine. At least that's how it was described to me over the phone. But of course, I don't really see what's happening inside there. If I could, I would pull her out of there, but I don't have the option. You know what? I really don't know what to think. I'm a bit confused by this whole thing. So in terms of recommendations, actually, that were made by family members and all the people that we interviewed, I think it's very clear that management and staff play a major role in the life of residents. And this role can be used for better or for worse. And we have seen based on these interviews, the greater flexibility and the maintenance of physical and emotional routines are really essential. And I'm sure that all the other studies that you have heard today have supported that. Both the social care and medical care and emotional care, all of these things should be provided on a regular basis and should not be interrupted even during the pandemic. And also it was very clear that the more transparent the measures were, the more comfortable residents and family members were about accepting them. If I move on to just general recommendations about the way we should be addressing this pandemic from now on. I think that it's very clear that we are all in this together. And I think that over time, the rhetoric has changed. And it's clear now that it's not only a disease of older people, and that it does not make sense to put older people in their homes and go back to life as usual. This is no longer discussed in most places. I also want to note that there have been multiple incidents of intergenerational solidarity, even in long-term care settings where people came over and played music and tried to really entertain the residents, even from far away. So this should be acknowledged. Nonetheless, I would conclude by saying that a pandemic is really not a reason for human rights violations. And we should not throw away the baby with the water, in my opinion, which means that we still need long-term care system. We still need institutional care, I think, not because this is necessarily the most desired alternative for most people, but because this is a sustainable alternative that has to be there, but it has to be humane and it has to be respectful of people's wishes, and it cannot really be as ageist as it has been during the pandemic, especially during the early stages of the pandemic, because really I think that at the risk of, or in order not to take the risk of the pandemic, human rights have been violated. They have been violated in the community as well. But when it comes to older people in long-term care settings, clearly, these are the people who have experienced the worst treatment. I'm going to conclude here, since I do come from the framework of ageism. I'm going to conclude with the WHO campaign slogan. Their vision is a word for all ages, and their goals are really to change the way we feel, think, and act towards age and aging. When I first heard this vision and goals in 2016, I was extremely optimistic, thinking now there is a global campaign to combat ageism. We are entering a new era. After the pandemic started, I became extremely depressed, actually, thinking that, or seeing and hearing things that I have never expected to hear and see. And I think this really has brought maybe the best, but definitely the worst of people, at least under certain circumstances. But now I'm hopeful again, because I think that maybe it is an opportunity to change our priority and to change our thinking about long-term care settings, about older people in general, and about the use of age as a single criterion for the allocation of resources and services. The two papers that are discussed are actually available online, and you're very welcome to check them out. And thank you once again for your time.
Thank you very much, Liat. And as we have quite different papers and we also have a bit of time, I'd like to take the question separately in this session. And I particularly wanted to comment. There's one thing that you said that I've written it up in capitals in my notes that we may have to review. As you know, we have launched this couple of days the LTC COVID International Living Report on COVID and long-term care. And I've always been struggling on the use of the word vulnerability. And I really like your distinction between susceptibility and vulnerability. And I also wanted to highlight the fact that we still have many countries in the world where there isn't a policy to have even essential caregivers to visit care homes, and where we know, and as you know from the global scan that we contributed to recently, where we know that there's a lot more that can be done. And I just wonder whether there is also this confluence between ageism, ableism, and then I wanted to also, in terms of the language, we have also been thinking a bit about what the word institution means, and whether using this word is also something we have to be careful with, given that care homes don't have to be institutions, and we could consider that institutional features are something that detract from these places being homes, and something for us to think about in the future. So I just wondered if there's any other questions coming through and from other participants. And if not,
I see one comment that I agree with.
Oh,
that we should definitely
yes.
push for a convention on the rights of older persons, because it's very clear that once something unexpected hits the world, the first people to suffer, the first people to experience abuse of the rights are older people. So we definitely have to push to that. So thanks, Maria.
May I, Adelina? But it seems like that we are dragging our feet towards this convention time and time again when it comes to shove and push or whatever you say. I mean, we don't walk the talk kind of thing.
I agree, and I don't know why. Yes. Because I think, again, just like we have seen during the pandemic, older people get to be the last in terms of the priorities. And even if they need the services first, they're going to be the last to receive it in a variety of incidents worldwide.
Exactly. And sometimes we make it, not we make it feel, we say it out aloud, that kind of thing. The pandemic is their fault. If they're getting sick, it's because they're old. I mean, even the way we portray the news that, listen, an older person, not an older person has died of COVID, but rather an older person had underlying conditions and subsequently died of COVID. So it's because of the underlying condition, not because of COVID. You know what I mean? He was living with the underlying conditions just the same, but he got stuck with COVID, no? I mean, very, very feeble excuses, if I may.
Thank you. I think you'll find a lot of agreement in this audience. And yeah, I'd like to thank you for this also very, I'm a quantitative researcher, spent a lot of the beginning of the pandemic trying to understand how many people were dying and then struggling with how to communicate and understand all these other impacts. And it is, and I know qualitative research takes longer to be produced when it's done properly. And I think this is a fantastic example. So thank you very much. I see a hand from Crystal Nicoli.
Maria, I thought that was a very insightful comment you just made, because I think it's even at a higher level. It's like it was okay for them to die because they had those comorbidities. That was okay. Everybody else was shocked if someone didn't have comorbidities and they died of COVID. Oh, well, what happened here? And we did a lot of research about that. But for the older people, it's okay because they had those comorbidities and they were going to die anyway. So it's even one level up, and thank you for bringing that up.
Thank you. We may need also to think about, I often feel that when we have discussions about ageism and long-term care separately, and I think the pandemic has also reminded us that we also think about stigma on dementia and about ageism also as if they were completely different issues, and I think they've all come together. And I think we also may need to join forces as well between the different areas and approaches to study these problems and to then advocate. And I am really pleased to have started this discussion in this very last session of the last 2 days, and I hope that we will be continuing it. So we're going to move now to a different type of study. This is a very big study that has recently started in Catalonia in Spain. I have a very, very small role, so I have to declare an interest, and I'm delighted to see many of the members of the team have joined, and looking forward to the presentation from Pau. So you're going to introduce us the ResiCOVID project. All yours, Pau. You can share your screen. If you have any problem, we can support.
Good afternoon. Can you see me and listen me?
We can see the screen. If you press, yes, exactly that. Yes, now we can see it very well. Thank you.
Okay. So yes, I'm Pau Moreno. I'm a physiotherapist. I'm a PhD student participating in this study, the ResiCovid. ResiCovid is the short from Resi, which in Spanish means residencia, nursing home, or long-term residencies, and COVID. So it's the short from ResiCovid. It's a huge study, as Adelina has already said, and it's the evaluation of the impact of the COVID-19 pandemic on people and long-term care facilities of Catalonia and proposals for improving the care model. It's a project from the University of Vic. It's a city near Barcelona. And as Adelina has already said, it's ongoing. I'm not gonna present any results yet because it's an ongoing process. I'm just gonna present the project. It's a huge project, as you will see. Well, as huge as it is, it has many research groups contributing with it, and many others. And Xavier Gomez Batiste, which I believe he's connected. Yes, he is. The main investigator, the principal one, and many others. Adelina as well. Well, why this project? As you have already stated through all the workshop, care homes are probably where the impact by COVID-19 pandemic has been more significant, especially in nursing homes. Beyond the death toll, many negative consequences on the residents, families, and staff. And there has been no systematic and in-depth evaluation of this reality and Catalonia. So what are the goals of this project? The first goal, it has two main goals. The first goal is to evaluate the impact of the COVID-19 pandemic on their residents, their families, and their workers and their organizations in care homes from Catalonia. So it's not only about the impact on residents, it's the impact on the whole actors of these care home models. Our second goal is to build proposals for improving this care model. So it's two main goals. The first goal has three main branches. The first one is a literature review, consisting of an analysis of innovative responses in front of the of the pandemic from a national and international perspective. The second branch would be an analysis of big data from the Catalan Health Services registers of the population of Catalonia. And the third one is a population-based study. This population-based study has got a mixed methodology, a quantitative and a qualitative one, and we'll have a significant sample of care homes from Catalonia. It's not only about nursing homes, it's mainly about nursing homes, but it's got disability and long-term cares homes and mental health long-term care homes. So it's not only about nursing homes, but it's mainly about nursing homes. Of this sample, we will collect data from residents, families, and staff. It's not only about the residents, it's about all the actors of this care model. And we want to describe their basic characteristics, their experiences, care model, and the COVID-19 impact on them and outcomes. So this is the three main branches of the first goal. On the second goal, in which we want to build proposals for improving their care model, we will do it by a SWOT analysis. SWOT meaning strength, weakness, opportunities, and threats analysis. We will do it by taking advantage of the sample of this population-based study. So we'll do a SWOT analysis of the residents, families, staff, plus an international benchmarking in order to improve the model and quality of care. We have already 6 PhD theses vinculated on this project. We expect to publish between 10 and 14 publications in peer-reviewed journals. And we want to do a final recommendation report and a final webinar. We have, we are constantly updating in social media, in which in the next slide, you will see where you can follow us. And that's all. It's an ongoing process. It's been a quick presentation. I want it to be quick, because this way we can dig deeper by answering your questions. If you are interested in any of these branches or any of this huge project, I already said it's a huge and it's ongoing. So I don't have any results yet. You can contact me. You can follow us in Instagram, Twitter, or in our blog.
Thank you very much, Pau. And so have we got, so if you want to stop sharing, we can see if there are any questions, any hands up. I want to say it's very encouraging to see this investment in this really large scale research, to be able to really get a deep understanding of what's happened, and also seeing this variety of methodologies. I'm a bit biased in this comment, but it is really wonderful to see this effort, particularly in a country where there was a very deep and fast impact of the pandemic at the very beginning. There's quite a lot of work to unpick what happened. So I was wondering if there's any hands up, any comment for Pau. When as being a new project, I also wanted to say that we'll be really, really pleased to hear further from you when you start having some interim findings. And we plan to continue this type of workshops, and we plan to keep learning and sharing information. Any other comments before we go forward? I see the link has been put on the chat as well. And I think we're at the very end of a very long 2 days, so maybe the questions are not quite flowing, and there's a bit of tiredness. And maybe we move for now to the third presentation, which is the final of the day. And any questions for Pau, the rest of the team, please put them on the chat. So we're going to go to Lisa van Tol from the Netherlands, and we're going to hear about the COVID minutes study looking at isolation and distancing measures in Dutch care homes. All yours, Lisa.
Thank you very much, Adelina. I think you can now correctly see my slides.
Very well, thank you.
Okay. Yeah, so my name is Lisa van Tol, and I am a PhD candidate at the Leiden University Medical Center. And indeed, I would like to share with you the design of our COVID-19 minutes study, in which we have collected minutes of COVID-19 outbreak teams in Dutch long-term care organizations. And I would also show you some preliminary results of one of the topics in this large study, which is isolation and distancing measures. So as you know, nursing homes have been hit relatively hard by the pandemic. And I think it is good to first say that Dutch long-term care organizations usually have infection prevention and control outbreak teams. But in severe cases, they convert these IPC committees or outbreak teams into specialized outbreak teams, and all organizations did so for COVID-19. The main difference is that these COVID-19 outbreak teams also included representatives of the management and directors of the long-term care organizations. So not only were the COVID-19 outbreaks severe, but also was the disease still unknown, and therefore the outbreak teams had to make rapid decisions based on limited available evidence and guidelines. So both long-term care organizations, but also some national policy institutes, including the Ministry of Health, Welfare and Sports, approached us to ask if we could provide insight and if it was possible to set up a rapid exchange of experiences. And that's why we actually started our COVID-19 Minute study. Very shortly, this is our team working at the Leiden University Medical Center under supervision of Professor Achterberg, and at the University Medical Center of Groningen under supervision of Professor Zuidema. So we set up this study with the aim to describe challenges presented by, responses to, and the impact of the COVID-19 pandemic. And this is a multi-center study with a qualitative design. So we collected minutes of the COVID-19 outbreak teams via email. So we asked participating organizations to weekly share via email their minutes with us, and we did so from March 2020 until October 2021. In the first place, because we thought that during these times of crisis, this would also be a low study load for the participating organizations. And we have two kinds of outputs. So in the first place, we wrote summary reports on a weekly to tri-weekly basis that we shared with all the participating organizations, but also with the ministry and some other national policy institutes, so that they got a quick insight into experiences and that they could learn from each other. But of course, we also performed some more scientific analysis on longer periods of time that we collected data for. So 41 organizations from the Netherlands are participating, but all 41 consists of multiple nursing homes. So together they represent over 500 nursing homes in the Netherlands and almost 43,000 residents, which is more than 1/3 of our residents nationally. These are the 8 large topics that we found time and again in the minutes of the outbreak teams. I think they will not surprise you, but just to show for now that I will focus on isolation and distancing measures in these 2 large topics, isolation and visitor policies. So for this part of the study, my aim was to investigate what isolation and distancing measures were implemented in Dutch nursing homes, and also what challenges were encountered by the outbreak teams while doing so. And I analyzed the data using manifest content analysis, meaning that I stayed really close to the terminology that was used in the minutes. And I did so inductively. So after analyzing over 1,000 pieces of text, I identified 3 types of isolation and distancing measures. So there were 4 types of isolation measures, 3 types of distancing measures, and 2 types of building entry measures, and I will walk you through these. Starting with isolation measures. We saw that isolation in single rooms was implemented. So single residents who had to stay in their room after a positive test result, and only staff in full protective equipment could enter these rooms. But we also saw that cohort isolation was implemented, and this is isolation of groups of residents. mainly to their ward. But in the minutes, actually various terms were used for this type of isolation. Then isolation as in COVID-19 units. In the minutes, it was meant here that residents who were infected were transferred to special units where they had to stay until they were no longer infectious. But there was actually variation in when to choose for this type of isolation, because some organizations said that they transferred all their infected residents to these units, while others said that they only transferred infected residents if they were the only one infected within a ward, because they said, if already multiple residents within the ward are infected, we prefer cohort isolation. And of course, quarantine, which is different because it's more about residents who have possibly been exposed, but also here it was possible to choose for quarantine in single rooms or for groups of residents. And then the most important challenges that were seen here were adherence, mainly if it was about residents with dementia or residents who were wandering. Of course, they couldn't always understand why they had to stay in their room. And also for the outbreak teams, they found it really a challenge to limit the freedom of these residents. And they even called this ethical dilemmas. There was one outbreak team that even installed an ethical committee to discuss these kind of matters. And also some outbreak teams said that in these cases, if it was about residents who were wandering, they prefer to choose cohort isolation, because then the resident could at least move freely within the ward instead of only in one room. And other challenges for isolation measures were about housing and building structure for cohort isolation and also for COVID-19 units. So for example, for cohort isolation, it was not always possible. The building structure did not always allow for isolating wards from each other. An example here were fire doors caused a challenge. But also for the COVID-19 units, you actually needed preferably an empty ward within a nursing home where you could create such a unit. So this often asked for reorganization of empty beds, but we saw that regional collaboration could make things easier. So we saw nursing homes who actually decided to share one COVID-19 unit. Then for physical distancing measures, we saw physical distancing measures to distance residents among each other. So mainly group activities were discontinued, or they were organized with restrictions regarding location, group size, or limited to residents from one ward. We also saw distancing measures to distance staff from residents as much as possible. So for example, some outbreak teams implemented fixed walking routes through the buildings so that staff would not be in contact with too many different residents. But we also saw that cohorting staff, as it was called, was often done. So then staff members were allowed to work only in one ward or in one unit. But with already staff shortages being present, this was also difficult to do. So we saw that then sometimes exceptions were made to this cohorting staff. And then it was said that, for example, physicians who had to see residents in more than one ward or in more than one nursing home, they could do so, but only if they would see the infected residents by the end of the day or by the end of the week, and first all other residents. Or sometimes staff was allowed to work in multiple wards if there was enough time in between. illustrated by this quote from the minutes. And then I will not say too much about visitor policies because I think a lot has been said about it over the last 2 days. Just that the most important challenge for outbreak teams was to deal with residents' relatives who found it difficult to adhere to visitor policies. So for example, there were visitors who took off their mouth masks or ignored instructions from staff. Some outbreak teams choose to deploy security guards to keep an eye on the visitors, or they decided that they could deny access to visitors who had caused disturbances before. And then very briefly, building entry measures. We saw some general building entry measures. So for example, medical and paramedical care providers who were allowed to enter a nursing home only in emergency cases or only on doctor's prescription. Allowing hairdressers to enter nursing homes was often discussed. And for example, volunteers were most often allowed on a case-by-case basis, so only for residents who really needed them. And then organizations, of course, also implemented restrictions to admitting new residents. So if this was about quarantine, again, adherence, especially of residents with dementia, was a challenge for outbreak teams. In these cases, they sometimes choose to customize the policies. So then, for example, they choose to test or to monitor symptoms, or to ask the resident and their family to apply quarantine at home before admission as much as possible to overcome this challenge. And another challenge was hesitance of residents to admission. So, for example, they did not like the idea of strict visitor policies. And for example, that they could not get a tour through the building before they were admitted. So some outbreak teams try to overcome this challenge, for example, by organizing customized tours via video calling, so that at least the residents could still see the place that they would be admitted to. Which is also illustrated by this quote. So this is an overview of what I just told you. Isolation measures where the main challenges were limited freedom and building structure. Distancing measures where adherence and staffing were challenges. And building entry measures where hesitancy was a challenge. I think it's good to notice that most of the measures that were implemented were in line with the guidelines and policy advices in the Netherlands. So although these have evolved rapidly, they apparently still offered good guidance in these turbulent times. A limitation of our data is that minutes are often brief descriptions of decisions that were made. So they often provide limited context to these decisions. So therefore, we think it is important to also discuss our findings with staff and to get insight into the context. And that's also what we are working on right now. Still, we think that our results have been of input for the long-term care organizations, also because we already shared the summary reports on a weekly to tri-weekly basis, and that they can also be of input for policymakers, politicians, and scientists, because we think it is important to learn from the challenges that were encountered to provide them from being encountered again, but also for long-term care innovations on the long run. Feel free to contact us. The first article about our COVID-19 minute study was published last week by BMJ Open. So if you are interested, please have a look.
Lisa, thank you so much. Would you mind putting the link on the chat if you have it to hand, the article? This is fascinating. And I know this is now late in the day and we've had a very long time, but I want to emphasize how important this work is. And I'm saying that from the perspective of having seen some of the modeling that has been used to inform the responses to the pandemic and some of the assumptions that are made about how just because a measure was announced, assuming that all care homes could implement it just like this, without considering the physical layout, without considering the resources. And it's always been really difficult to get to this information about how much were measures really implemented and what were the barriers. And I think this is such a creative approach to getting to that information. I do have one question. I'm going to first go to, I think Crystal has the hand up, and then I'll save my question for later. So Crystal, you'd like to go ahead?
Hi, Adelina. Sorry, I don't have my camera on today. It's breakfast time here in Canada, right? I'm kidding. Listen, Lisa, I think this is a really good methodology for research. I mean, it matches family caregivers' observations in the home, findings, and I think it would be a great research methodology if some researcher out there is thinking about reviewing the minutes of family councils, patient advisory groups, seeing what kinds of decisions were made and interventions were suggested by those groups, and how they were implemented in homes. Because I think a lot of the interventions actually that homes came up with on the spot, quick basis, were often a result of things that family caregivers brought forward. Do something this way, do something another way, this is what we need. So I think that would be an excellent research project, and kudos, excellent to hear your findings. Thank you.
Thank you very much. Yes, I also think that it is a really nice method that also has a low burden to staff during times of crisis. And I didn't show you now, but we collected minutes over a long period of time. So it also enables us to see the shifts between the first wave and the second wave and what decisions were different. So thank you very much. I think there's much more to analyze in this data.
Yeah, it'll be great to see the second wave, your next set of findings, for the next time period. Thank you.
Yep, we will follow you very closely. And my question was, maybe that's not such an issue in the Netherlands, but in quite a few countries, there is a lot of concern by the care homes of being prosecuted, especially if they have not been able to implement the measures. Or if their practice has diverged from the guidelines. And I was wondering whether this was an issue for you when trying to access the minutes, and whether this put some care home providers off, because that might bias a bit your sample towards the ones that felt that we're doing better. But that's just one of these thoughts.
I'm not sure about that. I think we have a large sample, and we used to recruit organizations, we used existing networks, so academic networks for nursing home research in the Netherlands. So I think the sample is mainly biased, that it's mostly the organizations who are part of the academic networks already. And they tend to also be the larger long-term care organizations with more nursing home locations. I think that's the main bias that we have seen so far.
That's great, and that's very good to hear. That it also, I think there may be cultural differences as well in different parts of the world in terms of the also the threat of litigation may also be quite different in different countries. I see a hand from Crystal again. Feel free to comment.
I was just going to comment in Ontario, our government, which is a provincial government in this country, outlawed any lawsuits against the government or any government actors for COVID. So they shouldn't be afraid to share the minutes.
Oh, that's a very interesting move as well. So I think we're going to end for today. I would really, unless there's any other quick question for Lisa before we go, any last minute final words of the day? And I just wanted to say that's a great way to end the day. It's very grateful to the three of you for this last session. We are trying to capture everything we can in terms of learning and share it. I think these all three studies have they're very different and rich values to bring. I hope you contribute all your findings and learning also through the International Living Report. We do have sections on measures and experience of adopting measures. We have sections also on the other impacts of the pandemic that aren't to do with infections. So, and I know Liat has already contributed to that, and looking forward also to the work from Catalonia when you start having some data. Thank you all who've been here. Some of you have, I think, been here at every single session. I haven't calculated how many hours we've been online, but this was a lot. And I think we've had more over almost 60 papers from 20 or more countries. Trina, and I know that there are more people who would have liked to participate and haven't been able to. I think this is a great testament to our research and policy community. And I wanted to thank all of you. And yeah, I look forward to hearing more. Send us updates of papers, and thank you so much. And see you soon. Thank you.